welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
So for our first presenter, we have Rachel Smith, a PGY2 emergency medicine pharmacy resident at Hackensack University Medical Center, and today she'll be presenting on the evaluation of Ketorolac ceiling dose effects in pediatric patients in the emergency department.
All right, thank you very much for the introduction. As she mentioned, my name is Rachel, and today I'll be talking about Ketorolac ceiling doses for pediatric patients in the emergency department. Objectives for this presentation are to review literature evaluating dose ceiling effects for Ketorolac, analyze the clinical implications of new data evaluating dose ceiling effects in pediatric patients in the emergency department. First, a little bit of background to further contextualize some of the data we're going to see today. Ketorolac, as I'm sure we're all familiar, is an NSAID commonly used for acute pain management, particularly when we want to use an opioid-sparing approach. It works by inhibiting cyclooxygenase 1 and 2, which leads to decreased prostaglandin synthesis and therefore decreased pain and inflammation. Minor adverse effects can include headache, nausea, vomiting, dizziness, and injection site pain. Of note, this is an analgesic medication, but headache is still one of the more common minor adverse effects. And then major adverse effects can include GI bleeding, acute kidney injury, cardiovascular events such as myocardial infarction or cerebrovascular accident, and bleeding. The onset of analgesia is around 30 minutes, and time to peak analgesia is around 2 to 3 hours. This is derived from adult IV push data. However, there is some pediatric pharmacokinetic data that shows that a dose of 0.5 milligrams per kilo given IV yields approximately the same therapeutic concentrations over time as a 30 milligram dose IV given to an adult patient. And speaking of dosing, I've included the recommended Ketorolac dosing here as well. For adults, it is weight and age-based dosing, a weight of 50 kilos or greater and an age less than 65. The recommended IV dose would be 15 to 30 milligrams every 6 hours as needed. For adults who weigh less or are older, the recommended dose would be 15 milligrams IV every 6 hours as needed. And then with decreased renal function, as I have listed here, it's recommended to avoid use if possible. Of note, the maximum total duration of Ketorolac should be capped at 5 days. For pediatric dosing, there's limited data available to guide dosing in patients less than 2 years old. However, the recommended dose is 0.5 milligrams per kilo IV every 6 to 8 hours for a maximum of 48 to 72 hours total duration. For patients who are between 2 to 16 years old, the recommended dose, either IM or IV, is 0.5 mg per kilo every 6 to 8 hours for a maximum dose of 30 milligrams per dose. And then for adolescents 17 and up, the recommendation is to just use adult dosing based off of their weight. And again, a maximum total of 5 days duration. Now, there's a number of pain scales that we're going to be seeing in studies today, often as the primary outcome for some, but definitely assessed in all. And the most common are the numerical pain scales, where the patient just rates their own pain on a scale of 0 to 10, or the visual analog scale, which I've included here, where the patient is given this chart and told to mark on the chart where they feel their pain is. And this is measured in millimeters, ranging from 0 to 100 millimeters. Getting a little bit more into background literature evaluating Ketorolac ceiling dose effects, a lot of the available data is in adults. And so starting with that, the first study that we'll be looking at is a comparison of IV Ketorolac at 3 single-dose regimens for acute pain in the ED. This was a randomized controlled trial of Ketorolac 10, 15, or 30 milligrams IV in adults with moderate to severe pain in the emergency department. They were able to enroll 80 patients per group, and of note, if the patient felt that their pain control was inadequate at 30 minutes, they were allowed to get a dose of morphine 0.1 mg per kilo IV as rescue therapy. Patients were included on the basis of being 18 to 65 years old, having an initial numerical pain rating of 5 or greater out of 10, and having a type of pain that would be usually treated with Ketorolac as determined by the treating physician. Patients were excluded for the reasons that I have listed here for your reference, the most notable one being anyone who has already received a pain medication would be excluded from the trial. The primary outcome was pain reduction at 30 minutes, and secondary outcomes were the receipt of rescue morphine as well as adverse effects. I've included here a graph of the pain scores over time in the participants of this study. On the x-axis, you can see minutes since the Ketorolac dose, ranging from 0 out to when data collection was stopped at 120 minutes. And then on the y-axis, there's pain ratings ranging from 0 to 9. You can see here that between the three groups, the pain scores over time look fairly similar. I've marked the 30-minute assessment point for the primary outcome. And then it's not really surprising based off of that graph that they didn't find a significant difference in pain scores at 30 minutes. As far as secondary outcomes, the rates of morphine rescue were also fairly numerically similar over time, again, with data collection ending at 120 minutes. The rest of their secondary outcomes, they didn't find any large differences in adverse events. Dizziness, nausea, headache, itching, and flushing were the most commonly reported. However, they didn't use statistics on this, so we can't necessarily say that it's statistically significant or not. And then limitations of the study, because they didn't collect any data past 120 minutes, that would be the earliest expected peak effect of Ketorolac. So we can't necessarily extrapolate the similarity in analgesia into the peak effect of Ketorolac. So the conclusion we can draw from this study is that there are similar analgesic effects of 10, 15, and 30 milligrams across the time of onset of the IV Ketorolac doses. The second background study looks at 2 doses of intramuscular Ketorolac for acute musculoskeletal pain. This was a randomized controlled non-inferiority trial comparing 15 milligrams versus 60 milligrams given IM for acute musculoskeletal pain in the emergency department. They were able to enroll 55 patients in each group for a total of 110, and they included patients who were 18 to 55 years old, who had acute musculoskeletal pain that they rated as 20 millimeters or greater on the visual analog scale. And patients were excluded for reasons that I've listed here for your reference. Again, the most important being if they had received any analgesic medication in the past 12 hours, they were excluded from the study. Their primary outcome was the change in visual analog scale score at 60 minutes, and secondary outcomes included the change in VAS score at 30 minutes, as well as adverse effects. Again, I've included a graph of visual analog scale scores over time. On the x-axis, again, we have time ranging out to 60 minutes, and the y-axis visual analog scale pain level in millimeters ranging from 30 to 75. And again, I've marked the time point of the primary outcome assessment, and we can see fairly similar pain scores across time in each group. This study did actually include their average patient weights, which I've included here just so we can contextualize this with the pediatric weight-based recommended dosing a little bit. In the 15 milligram group, the average dose was 0.18 mg per kilo, and in the 60 milligram group, the average dose was 0.71 mg per kilo. And as a reminder, the recommended pediatric dose would be 0.5 mg per kilo. For their primary outcome results, they did meet their non-inferiority margin for the 15 milligram dose. Their margin was less than a 13 millimeter difference between groups for pain reduction at 60 minutes. They didn't find any need for rescue analgesia in either group. However, they did find that minor adverse effects were more common with the higher dose, such as injection site pain, fatigue, headache, nausea, and this was statistically significant. Limitations of the study include that it was intramuscular administration, which isn't exactly the same pharmacokinetically as IV, so it's not necessarily comparable to our other studies. But again, data collection was truncated before the expected peak effect of Ketorolac, so we can say that the 15 and the 60 milligrams IM appeared to be reasonably similar across the time of onset. The third and last adult background study is this comparison of IV Ketorolac at 3 different doses for treating renal colic in the emergency department. This is another randomized controlled non-inferiority trial of 10, 20, or 30 milligrams given IV to adults with renal colic in the emergency department. They were able to enroll 55 patients in each group for a total of 165. And they were included on the basis of having acute severe abdominal or flank pain that was determined by the treating physician to be renal colic. Patients were excluded, again, for reasons that I've included for your reference here, the most significant being the receipt of any analgesics in the past 24 hours prior to the Ketorolac dose. The primary outcome was the change in visual analog scale score at 30 minutes, and secondary outcomes included the change in VAS score at 15, 45, and 60 minutes as well. They also assessed adverse effects and any need for rescue analgesia after 30 minutes. Again, I've included the graph of pain scores over time, and we can see that again, with time on the x-axis ranging out to 60 minutes, visual analog scale score on the y-axis ranging from 0 to 100 millimeters, relatively similar pain control across time between groups, and I've marked the primary outcome assessment time point at 30 minutes here as well. So it's not exactly that they found no significant difference across the groups in their primary outcome. However, they didn't perform statistics, so this isn't necessarily statistically significant. For secondary outcome results, as far as the need for rescue analgesia, they found fairly similar numerical rates between groups and no statistically significant difference. Of note, participants were excluded from further data analysis after they had received rescue analgesia, so this is not expected to significantly affect primary outcome results. And they didn't find any statistically significant differences in minor adverse effects. Again, a limitation of this study is that they assessed only across the time of onset of different ketorolac doses and didn't actually assess the analgesic effect during peak effect of ketorolac. So again, we can conclude that there were similar analgesic effects of the 10, 20, and 30 milligram IV doses across the time of onset. Moving on to the pediatric data that's available on the topic, we have this study evaluating ketorolac dose ceiling effect for pediatric headache in the emergency department. This was a retrospective study of pediatric ED patients weighing 60 kilos or greater who were treated with ketorolac either 30 or 15 milligrams IV for headache or migraine. At this institution, they had a protocol change that started to cap pediatric ketorolac doses at 15 milligrams. So they used doses from before this protocol change, the maximum dose of 30 milligrams, versus doses after this protocol change, which had a maximum dose of 15 milligrams, in order to mimic randomization for the purposes of this study. They did allow the use of other analgesics such as acetaminophen, opioids, or even other NSAIDs outside of a 30-minute window before and a 30-minute window after the dose of ketorolac was given. Additionally, they allowed the use of dexamethasone, prochlorperazine, droperidol, valproic acid, magnesium, and triptans, all of which we know can affect changes in pain score over time in the setting of migraine, which they were specifically including in this study. As I mentioned, patients were included if they had a chief complaint of headache or migraine and they received IV ketorolac. They were excluded if they weighed less than 60 kilograms, if they were missing pain scores, if they were subsequently admitted to the hospital, or if they received these listed certain other analgesics within 30 minutes before or within 30 minutes after the dose of ketorolac. Their primary outcome was the receipt of rescue analgesia within 6 hours after the ketorolac dose, and secondary outcomes were the decrease in 10-point pain score after ketorolac. They were able to enroll 216 patients in the 30 milligram group and 62 patients in the 15 milligram group. Of note, greater than 80% of each of these groups received the permitted drugs for nausea and vomiting, which, as I mentioned, could potentially affect pain scores in the setting of migraine. For the primary outcome, they didn't find any statistically significant difference in the receipt of rescue analgesia. And for secondary outcome results, they found a difference in mean pain scores after ketorolac. Specifically in the 30 milligram group, they found a decrease of 3.9 out of 10, whereas in the 15 milligram group, so a lower dose, they found a greater pain score decrease of 5.1 out of 10, which was statistically significant. However, the repeat pain scores were obtained 80 minutes after the ketorolac dose in the 30 milligram group on average, and 109 minutes after the ketorolac dose in the 15 milligram group. And this was also statistically significant. And so the higher dose group was assessed during the onset of effect of ketorolac, whereas the lower dose group was assessed later, closer to the peak effect of ketorolac. And that may partially explain some of the difference in pain score decreases. Some limitations of this study include that they allowed other medications that may affect pain scores, as I mentioned, the pain scores being obtained at different times, so it's difficult to tell whether this is truly a dose-related effect, and the requirement of a weight of 60 kilos or greater for inclusion, which isn't necessarily applicable to a lot of pediatric patients. Conclusions that can be drawn from this study is primarily just that there's not a difference in the need for rescue analgesia between these two groups. Summarizing quickly what we've just been through as far as background information. First adult study, Motov et al. Compared Ketorolac 10, 15, or 30 milligrams IV and found no difference in pain at 30 minutes and no difference in rescue analgesia needs. The second adult study, Turner et al. Compared 15 to 60 milligrams IM, found a non-inferiority for the 15 milligram dose at 60 minutes as far as pain control, and none of the patients required any rescue analgesia. The third adult study, the Adenajad et al. Study, compared 10, 20, or 30 milligrams IV at 30 minutes, found no difference in the pain endpoint and no difference in rates of rescue analgesia. And then finally, this pediatric study, the Lefchuk et al., compared 15 versus 30 milligrams IV, looked at pain scores, but with no specified time point, did find that the 15 milligram dose was superior, but subject to the significant limitations I've just spoken about, and found no difference in rescue analgesia. So now, keeping all of this information in mind, let's move forward to the main study for today, the evaluation of Ketorolac ceiling dose effects in pediatric patients in the emergency department, which was published in the American Journal of Emergency Medicine in December 2024. This was a retrospective single-center study comparing the analgesic effect of IV Ketorolac with a maximum dose of 15 milligrams versus a maximum dose of greater than 15 milligrams in pediatric ED patients with acute pain. Patients were included if their chief complaint was acute pain, if they received IV Ketorolac monotherapy for analgesia, and if the dose was 15 milligrams or greater. They were excluded if they were adult-aged, if they received analgesics other than ibuprofen or acetaminophen in the prior 12 hours. So of note, they were allowed to receive ibuprofen or acetaminophen. If they were using chronic pain meds, they had sickle cell disease, if they had a chief complaint of headache, any contraindications to Ketorolac, or a lack of documented pain score was also excluded. Their primary outcome was the percent of patients with a decrease in pain score on a scale from 0 to 10 after the receipt of Ketorolac. Their first secondary outpoint was the actual amount of pain score decrease per group, as well as the need for rescue analgesia within 3 hours of the Ketorolac dose. Adverse events, specifically the ones they assessed for, were bleeding events, change in serum creatinine, and reduction in urine output within the next 48 hours. And then they did additionally perform a sub-analysis by the weight-based dose received, stratified to either very similar to the recommended dose, 0.45 to 0.5 mg per kilo, versus less than the recommended dose. They were able to enroll 89 patients in the cap dose group and 89 patients in the larger dose group, fairly similar in terms of age and sex, majority female, and generally on average around 14 years old. However, the dosing weight ranges were pretty different between the two groups. We can see that the median dosing weight, 62.7 kilos versus 58.9 kilos, is not all that different, but when we look at the interquartile ranges, 52 to 74 kilos versus 32 to 71 kilos, we can see that the larger dose group, surprisingly, actually weighed a lot less. And this is kind of reflected in the average weight-based dose, 0.26 mg per kilo in the 15 milligram group versus 0.44 mg per kilo in the larger dose group. Patients in both groups also had fairly similar baseline pain scores, similarly low rates of opioid use in the past 12 months, and similarly low rates of previous admission or surgery in the past 30 days. As far as reported pain locations, this was predominantly a population with abdominal pain. Over 100 of the patients seen were for abdominal pain, with the next 3 most common being throat, back, or musculoskeletal pain. And unfortunately, this was not broken out between which group had which types of pain. This is only the entire cohort in aggregate. For their primary outcome, they found that in the cap dose group, that 83% of patients experienced a decrease in their pain score versus 82% in the larger dose group, so no statistically significant difference. For the amount of mean pain score decrease out of 10, it was 4.3 in the cap dose group versus 3.5 in the larger dose group, not statistically significantly different. And for rates of rescue analgesia needed within 3 hours, similarly, there was not a statistically significant difference between groups. When broken out by weight-based dose received, there was a similar result achieved, 82% versus 83% of patients with a decrease in their pain score, no statistically significant difference. As far as adverse events, none of the ones they were specifically assessing for were reported. Most patients, fortunately, who receive Ketorolac for pain are usually able to be discharged, and a lot of these patients did not have repeat serum creatinine levels taken after the Ketorolac dose. No patients had urine output documented, and there were no reported bleeding events. The authors concluded from this that the administration of higher doses of Ketorolac is unlikely to improve analgesia in line with available literature in adults. And the study did have some strengths. The participants were generally in line with patients who are likely to receive Ketorolac for analgesia in the emergency department. For example, excluding headache, any patient who needs an intracranial hemorrhage ruled out is probably not getting an NSAID prior to the CT scan. Sickle cell crisis and chronic pain management may require a multimodal approach or may include patients who are a little bit more tolerant to some commonly used analgesics. I appreciate that they did the sub-analysis by the weight-based dose, which allows us to compare their results to the pediatric weight-based dose recommendations. As well, I appreciate the inclusion of rescue analgesia within 3 hours of Ketorolac as a secondary outcome, especially because this was the only outcome that was tied to a specific time point. However, this study was a retrospective study, and along with that comes some inherent limitations. It's subject to selection bias between which patients got the dose cap versus patients who didn't. We saw earlier that there were a lot of lower weight patients who got doses higher than 15 milligrams. And we simply don't know if those patients had a different type of pain, if they had more pain, what was influencing the dosing decision. We're unable to assess the rates of ibuprofen and acetaminophen use prior to arrival. And there were no limitations placed or timeframes reported for the pain scores. They used the next available pain score, which could have been before the onset of Ketorolac, it could have been after Ketorolac wore off, or it could have been right at peak effect. And we don't have any way of telling where in the time course pain was assessed. Additionally, there was that large difference in weights between groups. And we don't have the distribution of different types of pain in each group reported. And the primary endpoint was only assessing any change in pain score, not the amount of change in pain score. Additionally, I would have liked to see minor adverse events reported, things like the headache, dizziness, GI upset, etc. So my key takeaways from this study are that adolescent patients presenting to the ED with predominantly abdominal pain who received Ketorolac 15 milligrams versus greater than 15 milligrams IV were not observed to have a difference in the rates of rescue analgesia within the next 3 hours. But based off of the significant limitations of this study, there's insufficient evidence to determine whether a 15 milligram dose cap really should be implemented. And I think we're going to need some further randomized trials in order to determine if a dose ceiling effect truly does exist. So with that, here are my references. And what questions do you have for me?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest. It should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.